The aortic arch, we want to evaluate that as well, obviously with color and spectral Doppler. Our normal direction of flow we know is going from the ascending portion to the descending portion. We turn on our color. You definitely want to identify the area of highest flow and put your sample gate there. We use that 120 centimeters per second as normal in our arch as well, again, just because we're trying to keep things pretty simple. We tend to turn on color, obviously, and we also tend to move our sample gate throughout the arch. That could just be because we're obsessive. If you don't do anything else in the arch, you want to make sure you pay particular attention to the aortic isthmus, which is just this area past the head and neck vessels before you get to the descending aorta. And that's because that's the most common area in the fetus for a coarctation to occur. So if you don't do anything else, make sure you look at the aortic isthmus. In this arch, we see flow going away from our transducer as it should, so it's below our baseline, which is correct. Again, we measure peak systolic velocity. It was 68.4, so that was below our 120 centimeter per second threshold, and this would be considered normal. Here, just a real-time image showing, again, color. Look at flow throughout that arch. You definitely want to put your sample gate in the area you see those lighter hues, because that's the area of the fastest moving blood or your highest velocity. But again, always make sure you evaluate that aortic isthmus, which is just past those head and neck vessels. Okay, you also want to look at the ductal arch. The ductal arch should be evaluated with color and spectral Doppler. Normal direction of flow is from the pulmonary artery towards the descending aorta. That section in between will be our ductus arteriosus. And once again, we use our 120 centimeters per second cutoff for normal. Having said that, you need to keep in mind that with the aortic arch, regardless of where you are in gestation, it probably won't vary much from this 120. It may be a little bit higher later in gestation, but not significantly. That's not true with the ductal arch. As these fetuses grow, particularly late in the third trimester, the ductus arteriosus kind of runs out of room, even though it's still growing. So it can become very tortuous, and it can create these anatomical stenoses, which will result in velocities that can be exceedingly high. So if I was looking at this fetus in the second trimester, I want to see something around 120 centimeters per second. If I'm asked to look at this patient late in the third trimester and I see velocities even as high as 170, 180, 190 centimeters per second, that could be due to the tortuosity of the ductus arteriosus. So you want to make sure you get a good look at it. The other thing to keep in mind is really ductal constriction, which I mentioned is what they might be concerned about, particularly in moms who are on things like indomethacin or steroids if they have an autoimmune disease. It's reflected by increased diastolic flow. So that's really what they're going to look at to make their diagnosis, regardless of what the peak systolic velocity is. Okay. You can see in our abnormal image down here, we have quite a bit of diastolic flow. That's different than what we see here in our normal flow through the ductal arch. Okay. As I mentioned earlier, indomethacin has been associated with a constricted ductus later in pregnancy. Steroids have been associated with it later in pregnancy, usually. Overall, the risk of a constricted ductus will increase a little bit with advanced gestational age. So in very rare instances, you may see it without truly identifying a drug-related reason for it. But drug-induced ductal constriction, again, is reversible. If I was to see something like this, again, increased diastolic flow even though you can see here the systolic velocity is very high as well, it's almost 240 centimeters per second, then what they do is take that mom off that medication and it should reverse itself. Total occlusion of the ductus where you wouldn't see any flow through it is exceedingly rare, but it might occur. So one more reason you want to thoroughly evaluate the ductal arch. And here's just using color again, looking for that flattened structure, no head and neck vessels, so I know that's my ductal arch.